Macomb County Community Mental Health, guided by the values, strengths, and informed choices of the people we serve, provides quality services which promote recovery, community participation, self-sufficiency, and independence.
Thank you. Next is adoption of the agenda.
Motion to adopt.
Seconds, Schmidt.
Motion by Lori, supported by Dana. Any comments or questions? Or was that Selena?
It was Selena, but I'd second too.
You can get the next one, Selena. Right. Any discussion on the agenda? All in favor signify by saying aye.
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 Agenda is adopted. Next is a hearing of the public. This is the opportunity for anyone from the public to address this board. You have 5 minutes to address the board. If you are there, anyone from the board, anyone from the public wishing to address this board? Anyone from the public? Make sure you take the mute off. Anyone from the public? All right, seeing none, we will move on to item number 5, which is approval of the minutes of the regular meeting of the full board held on June 24, 2020.
So moved. Burke?
Support, Schmidt.
Motion by Burke, support by Schmidt. All in favor?
Aye.
Opposed? Minutes are approved. Next is approval of the standing committee meeting minutes and recommendations of the program and budget committee held on July 8, 2020.
Move to
Motion
approve
by-
O'Connell.
O'Connell and support
Philip.
Fantuzzi.
and support by Fantuzzi. All right, O'Connell, support by Fantuzzi. Any questions or comments? All in favor signify by saying aye.
Aye.
Opposed?
Aye.
All right, the minutes have been approved. Next is item number 7, which is a request to approve items A, B, and C, which were items that were discussed and dealt with at the program and budget meeting 2 weeks ago.
Madam Chair, I'd move to approve items 7A, B, C, and D.
All right, motion by Phil,
Support.
support by Tony.
Correct.
All right. Any further discussion on that we've already discussed it? Any additional questions or concerns? All in favor signify by saying aye.
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 Opposed? Those items have been passed and approved. Next is an item number 8 to receive and file the Community Mental Health Board Committee lists.
Kathy, I'm sorry.
Is that a
So
motion by-
Kathy, that's a motion to approve rather than
Okay,
receive and file under the bylaws.
all right, well, we'll approve them then. Motion to approve, thank you. Support,
Yeah.
continued support by Bush.
I'm sorry. It's Burke. It might have sounded.
Sorry, Burke.
No worries.
Oh, my goodness. And this is the same list that you had seen before with one addition at the end, and that is a representative to the, what is it? What committee? Megan Burke is the, Megan, what's the committee?
I think that we
Compliance.
were just compliance. Yeah. Does it have an actual title or is it just compliance committee?
It may have a title, but we know which one it is, so.
Okay, perfect. Thank you.
All right. Any further discussion? All right, all in favor of approving, signify by saying aye.
Aye.
Opposed? Motion carries. Next. I lost my place.
Resolution.
Resolutions, are there, I don't see any resolutions. Are there any resolutions, Dave? All right, then we'll move on to voucher listings. Here's our opportunity to approve the payment of the bills.
So moved. Support.
Support Bush.
Okay, support by who? Was it DeGovan?
Yes.
Okay, thank you. Any questions or discussion on that? All right. All in favor signify by saying aye.
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 Opposed? The voucher list of bills is approved. Next is the management report.
Kathy, I have a text message from Richard saying he's having some technical problems. So with your permission, we could go to Cindy Conal.
Yep, let's just move down the line then. And Dave, I'll let you take this over and you can introduce as appropriate.
Sure. This is a continuation of the director reports. So Cindy Conal is our director or chief quality officer, and she's prepared a presentation, which is inclusive of several documents that you as board members need to be aware of and you need to review on an annual basis. So with that, I'll pass it to Cindy. I am going to stop my screen share, Cindy, and then you should be able to take over.
Okay. Hi, everyone.
Nice.
Hello.
Aye.
Okay, so I'm going to discuss our quality team. We have, it's a quality department, and basically we're in charge of ensuring that the quality for all of the services is exceptional through Macomb County. I'm the chief quality officer, and the person directly under me is the quality administrator. That's Lori Baumgart. We have two quality coordinators, Laura Duncan and Ambrosia Jackson, a quality specialist, which is Vincenza Randazzo, and two quality assistants who are Amber Rentz and Lori Doyle. Oh, it's not going to let me do it, is it?
If you go, there you go.
Okay. The quality team also includes two case managers, Anna Marie McIndoe and Stephanie Roy, who go out and do the audits.
Yeah, for you. I'm going to be your favorite sister when you see that.
Linda, you're not on mute. Two quality office assistants, which are Cheryl Morick and Cecilia Gaglio, and a quality therapist who works for Michigan Rehab Services, and his name is Jack Betts. Our functions include the HSAG ISCAT, which is Health Services Advisory Group Information Systems Capability Assessment Tool. We have a performance improvement project also through HSAG. That's who the state contracts with to make the state's not doing audits like they used to. So they contract with HSAG to come out and do audits for us. My computer keeps jumping, I'm sorry. We also do the quality provider meetings. That's on a quarterly basis. We monitor the key performance indicators, which I believe you might get copies of. I'm not sure. There's numerous KPIs, which is what we call them. And it's to measure our ability to get people in for services and to provide those services. We also do a quality council, and our state work groups and modules, we have people sitting in on those and participating in those. We work on data dashboards to ensure that we have data that is accurate. And the dashboards help give us, what do you call it? The dashboards assist us in looking at the data on a large basis. So we've got graphs, we've got wheel charts, that kind of thing to show us how we're doing on our dashboards with all of our data through Macomb County. We're working on the Certified Community Behavioral Health Center, the CCBHC quality functions. We're working on healthcare effectiveness data and information set measures, which are the HEDIS measures. We participate in the integrated care organization quality calls, the internal and external audit coordination, quality assessment and performance improvement program, our QAPIP, and our work plan, and incident report tracking and trending. We also track and trend cause of death. We do root cause analyses, which is to analyze incidents that might occur. Our department is part of the Clinical Risk Management Committee, where we identify different risks. We ask the providers to perform those root cause analysis if there's certain incidents that occur. We participate in the Medication Management Initiatives Committee, the Performance Improvement Committee, the Mental Health Disparity Improvement Committee. You'll be hearing much more about that committee moving forward. It's a new initiative. It's to ensure that all populations, including minority populations, receive the same type of treatment as everyone else and have the same access to care as everyone else. We work on the focus modules and the improvement, and focus is our electronic medical record. We do the national core indicators for the state, policy revisions. We conduct clinical and technical audits. We provide the provider and consumer satisfaction surveys. We work on CARF, the crisis plans, credentialing and privileging processes. We conduct the credentialing and privileging and training audits throughout the system. Relias training system-wide, that soon will be going over to the training department, but we're still doing that. The peer evidence-based coordinator, the peer state liaison, and data resources. We do have quality audits that are completed by external sources, and those are the HSAG Performance Measurement Validation Tool, the HSAG Compliance Audit, the HSAG Performance Improvement Audit, CARF, which will be coming out, well, they're not coming out. So CARF will be providing their audit in either September or October, and it's going to be via Zoom or Microsoft Teams, rather. So we will be working with them in this format, and we will be asking some of the board members and to come to the entrance, exit, and one or two to be meeting, probably you, Kathy, if you have time, to be meeting with the CARF auditors. We also are audited on the 1915 C waivers, our autism, the integrated care organizations. We get audited by them, and our express audit, we provide support for that. The quality internal audits, this is where we go out and we audit the other providers. So all of our providers in the system, we have to ensure that they're providing quality care. So that's residential and skill building, primary providers, which are case management supports coordinators, the autism, the waiver staff qualifications and training audits. We audit the hospitals. We audit all of the ancillary private duty nursing and nursing respite, the clinical audits, child training, CLS and respite, access, fiscal intermediaries, assertive community treatment audits, and the crisis stabilization and crisis residential audits. Those audits go on all year. So we continue to do that on just constantly. We have audits going on. The QAPIP, the updates that I have for you today are the QAPIP, the third quarter update, which was attached, and the incident reporting that was attached. So that, in a nutshell, is quality. Let me get out of this screen. The next one I'm going to be presenting as our QAPIP. So our QAPIP is basically our mental health quality improvement annual work plan. This is our third quarter. And if you look at the indicators on the left, I believe I came in January and showed this to everyone, where all of our indicators are on the left. So this first one is we ensure all federal, state, and local contractual obligations are met. We track and trend the key performance indicators. As you can see, this is the second quarter report up on top, and then the third quarter report. Once again, we've got improve access to services, the second quarter report, and the third quarter report. I'm not going to go through all of those. Everyone got a copy, and it's at the end of the fiscal year is when we'll go over it in detail. It has to be brought to you on an annual basis so that you can actually look at it, read it fully, and we'll go through it completely. On a quarterly basis, though, I just want to begin to bring these to you so you become familiar with them and see if you have questions if you've looked at them. The next is to expand integrated care efforts, increase engagement in employment services and improve trauma services, ensure consumer rights, customer service improvement, the PIHP accreditation and the workforce development and staff satisfaction, network adequacy, increase report availability and accuracy, operate within CMH allocations and restore the financial risk reserve, increase quality services throughout the network, improve opioid treatment services. So those were the categories that we chose this year to be working on. We will be asking you for your input come October 1 on any others that you would like to see that we'll be working on and providing you updates on a quarterly basis, at least annually, but if we can, I want to be able to provide quarterly. So I don't know if anyone has any questions about it, if you want me to go into more detail on them.
Cindy, I have a question. This is Tony Palua.
Hi, Tony.
About 6 pages back, you mentioned something about increasing the potential for jobs. Can you find that and just tell me what page it's on?
Employment?
Yes. Increased employment, I just saw that.
Let's see.
You could search the document for the word.
Yeah, somewhere around there, if you can just.
There it is.
Page number. Yeah.
Increase engagement in employment services. So we have that on hold at this point. I know Dave is working on that with a couple members of our team. Employment has been a very difficult thing to get through. And he has identified, well, I'll let you talk to it, Dave.
Well, just tell me the page number that you're on right now, would you please?
Page 9.
90?
9.
9, thank you.
It's number 4.
Thank you.
Just to quickly add, the employment is an area that I've wanted to see grow since I've started. The pandemic has definitely set us back. I was in communication today with Michigan Rehabilitation Services. We do have a interagency cash transfer agreement, or ICTA, with them specific to supported employment. We're looking at making some changes to that rate now, basically reducing it because of the reduction in service during the pandemic. But we will be working to increase that. And then I will be having some internal meetings as well, focusing on employment and ways to increase those services. With the skill building centers shut down and having difficulties in reopening since their group settings, their center-based programs, I think we are a lot better off expanding in the community-based employment. Again, there's different obstacles now, but nothing that can't be overcome. And working with to build our job coaches up and our employment options for the people in Macomb County. Thank you, Cindy.
Dave, I have a question. What are employment services?
It's actually very interesting. In the Medicaid manual, there's a single code for supported employment, but it covers job development, job searches, and the actual job coaching. So it'll pay for a one-on-one person to work with somebody in the community to help them get acclimated to a new position. It's available to anybody. It's the B3s or the C waivers. And it takes close work with the community, with the employer sites. There are some benefits to the employer, and that's where partnering with Michigan Rehabilitation Services comes into play. We do coordinate benefit, so MRS would pay for the initial job evaluation, kind of like a skills, to see what type of job the person's capable of. But the ongoing job coaching would be on us. So it's a really good program. It covers a lot. Currently, it's set up for face-to-face services only, and that creates some difficulties because if I'm working with somebody indirectly to get their resume out, set up interviews and things like that, I can't report that. But we can work around all of those issues as well. So hopefully next year we'll see a nice steady increase in this service.
Thank you.
Any other questions? Okay.
All right, Richard has joined us now. Overcame his technical difficulties.
Thank you, Cindy.
Okay, Dave, did you want me to go through the incident report, or I think they have it there, so.
I'm sorry, Cindy, I didn't mean to cut you off at all.
Oh, that's okay.
It's up to the board members.
Yeah, go ahead. If you could give us the incident report.
Okay. I'll be quick. Okay, these are incident reports. Our overall incidents.
Can you do the slideshow view again, Cindy?
Sure. There we go. Okay, these are the 2020 overall incidents. We had 995 of them. As you can see, we check those according to the frequency of the incident. So the most frequent incident we had was when 911 was called by staff due to behaviors, the medical hospitalizations, medication errors, and in medication errors, we really don't have that medication errors. That also includes if someone refuses their medication. Falls, deaths, use of physical management by staff, COVID. COVID is one that we just put in there. It's not one that the state has had us track to this point. Harm to self requiring EMT and harm to others requiring EMT. These are the incidents by quarter. At quarter one, we had 326, quarter two, 371, and quarter three, which just ended, we had 302. When we see numerous incidents of the same type, we track, we trend all of these incidents, and then we meet as a group to come up with remediation. Say it's choking. We had quite a few incidents at the group homes in the past, and what we did was we came up with a remedial action. We put Dr. Hosef, that's back when Dr. Hosef was here, put a lot of requirements in place to remediate those issues. These are the COVID-19 cases. We've had 15 deaths within our system. 15 people have been hospitalized. 9 people were managed within the facility, and by facility, we mean a group home, a nursing home, that type of facility. And then managed at home is that they were managed in their personal residence, but they were identified as having had COVID. These are the cases by quarter. We only had, that's quarter two and quarter three. We did not have any cases in quarter one. Harm to self requiring EMT. As you can see, these are 2 we had in the third quarter. 4 of them in the third quarter, and 1, there were 5 in quarter one. Harm to others requiring EMT, we only had 1, and that was in quarter one. 911 calls by staff due to consumer behavior. These are medical hospitalizations. These are when people who are in our residential facilities have a medical hospitalization. Use of physical management by staff, you can see according to provider. These are the overall deaths from 2020. So we track and trend those. The reason that pending is so high is because we're still awaiting a death report from the coroner. And these are by quarter. These are 2019 overall deaths. This is the age of time, the age at the time of death. So in 2019, our average age of people who passed away who were in our services was 51.5. In 2020 so far, it's 55.8. That was a big initiative to begin to look at why people were passing away younger. The doctors were aware of the need to be looking at the medications to make sure that people were getting into their primary care the way they should be, that we began to track blood pressure, we were tracking weight, so that's one of the reasons that it's gone down. I mean, gone up. By quarter, this was the average age of death, and if you look at it, there are a couple outliers here, such as 0 to 9. We had a child who passed away, 10 to 19, another child. So it does skew the statistics down a bit. If you remember, we also, not only do we service mentally ill children and adults, we also service the IDD population who have many physical disabilities. The fiscal year 2020 age at time of death by quarter, that was the third quarter. These are the medication errors. As you can see, refusal is one of the largest ones, not passed. And then we had some wrong med passed. This is the 2020 overall critical incidents, and critical incidents are basically those that occur in certain programs. Those are our waiver programs, our My Health Link programs, and then any deaths at all in the system are also identified as critical incidents. That's Q1, Q2, and Q3. So those are incidents. Like I said, quality will track and trend anything that's within the incidents, and then we identify any remediation that we can offer. And then we pass that out to the system to identify how it can be fixed. Any questions?
Oh, yeah, Cindy, I do. Are these people who we are currently serving? How
Yes.
does one get tracked?
Anyone we're serving.
Okay.
So if one of these things occur, it's up to the case manager and whoever identifies the incident to send us a form. And on the form, it tells us, okay, why are they sending it? What happened at that time? And then at that point, Office of Recipient Rights also looks at the incidents to make sure that there's no abuse or neglect going on. And then we look at it for the tracking and trending purposes. We are getting a module that we're going to be able to use. We've got it partially in place. We're really excited about it because it's going to help us a lot with the tracking and trending. So as soon as that's fully in place, our EMR PCE, for the electronic medical record, they're revising it. So as soon as that's revised, we'll be able to implement it fully and be able to track and trend much better than we are now.
All right, thank you.
Mm-hmm.
Cindy, my Madam Chair.
Yes.
Hey, Nick.
Cindy, just two quick questions. Will you be providing these PowerPoints to us, or is it on the internet?
I can provide these to you, Dave. It's up to you on a quarterly basis.
No, I just meant your PowerPoints.
They're currently in
This-
the packet, Nick, that went out. You have them open.
Oh, okay. It wasn't in the packet that I opened up, but there may have been a later one, or go back on. If it's on the online one, that's fine. The second question, Cindy, is as we're tracking the COVID incidents, how are we doing in terms of each of the locations? There haven't been as many as we feared. That's good news. But one of the fears, at least I've had all along, is that once you get one, it's going to spread throughout a group home or a group of group homes if you have traveling
So
casework.
And I do have a PowerPoint that tracks that. However, I didn't send that to you. So Dave, can I show that to them?
You can send it later, I think. But,
Okay. All right. So we can attach that and send it on. And
I'm just looking for an evaluation as to whether or not how we're doing at being able to, when it cuts into the home, keep it from spreading from one patient or one consumer to another.
We haven't had any homes shut down as a result of the pandemic. We do have plans in place, and providers have been doing just an amazing job themselves about covering the staff shifts that are needed, keeping people safe in the community. It was a real concern when it first hit, and we were kind of day by day. It has yet to happen, and I give full credit to our providers and the people in the community. They all have their own crisis plans, infection control protocols that they're following. Worst case scenario, you saw you passed the agreement for Pontiac General. We did have those in the Oakland County home that were relocated to the isolation beds for the inpatient hospital. But to date, those are the only ones.
Yeah, it seems to me that they're doing and yeah, you can only give the credit to the providers. They're doing an amazing job at isolating or whatever it is they're doing, so that you don't have, when you have one, you suddenly have six. And it's very impressive.
And if I can say, it's not just the providers. I think Dave did a great job through this whole thing, because we had the providers meet on a weekly basis. Dave had quality call all of the providers at least weekly to see what we could do to help them. Dr. Serpa was working with a lot of the staff on getting out the PPE. So I think it was a great job. Yeah.
Well, congratulations to everybody, because I'd been worried about that from day one. Dave, we had discussed it early on in the pandemic, and to contain it that well is really exemplary. Obviously, we wish we'd had none and no deaths, but the size of our group and the closeness of group homes, to be able to contain it is, I know, a very difficult thing. And the fact that we have contained it as much as we apparently have is really impressive. So congratulations to everybody involved.
Thank you. And we have had providers who have internally relocated people between their homes in order to make sure they had sufficient staff coverage or sufficient room to keep people socially distant if needed and things like that, but no crisis where everything was shut down. So knock on wood.
Yeah.
Thank you, Cindy.
Thank you.
Kathy, Richard has joined us now.
Yeah, go ahead. Richard?
Good evening. My apologies for some technical difficulties. I will share my screen. Hopefully you will be able to see the May monthly finance report. If you could confirm that is shown.
Yes.
Yes.
Yeah, we can see.
Excellent, thank you. In front of you, you have the May 2020 monthly finance report, just a few highlights. Our revenue trends, you'll see that for the month of June, we did show another spike. That spike is related to the direct care wage that was paid in the month of June and intended to cover costs related to the months of April, May, and June. So that is the cause for our spike that we're showing. We did receive that payment right at the end of June. We do, just related to the direct care wage, the governor did sign Senate Bill 690. It was posted to the Michigan legislature website. And so we have confirmed that Public Act is in effect. So we will be getting hopefully an additional payment from the state related to July, August, and September. We have a rate setting meeting with the state of Michigan tomorrow, and hopefully we'll get an update on when we might anticipate the revenue related to that additional pass-through. In terms of eligibles, while we have seen a little bit of an increase related to March, April, and May over January and February in eligibles, we're not seeing what I would call a spike in eligibility at this point in time. So again, keeping our eye on that and not sure if we're going to see that spike start to show up in the data as the 6-month retro eligibility is being processed. So we'll keep our eye on that going forward. Moving on to some of the balance sheet trends. So because of the increase in the revenue, we are showing an increased cash balance as of May compared to September 2019. We also have received most all of our receivables from the state of Michigan are also recognized at this point in time, so that results in a decrease in our receivables as of May 2020. On the liability side, we do hold open our accounts payable longer at the end of the fiscal year, so that explains the decrease we're seeing in vendor payables comparing September to May. And then both the amount due to the state of Michigan and the employee payables are relatively consistent from September to May. So no major highlights in that area. Looking then at our change in net position, assets are up, liabilities are down. So our net position as of May is higher by about 20 million. This is basically unspent Medicaid funds at this point in time, which we'll get to in a minute. When looking at our revenues and expenses, again, just from a projection and a trend perspective, again, this is annualized. So we are anticipating that if we were to annualize May's results, we would be up about 22 million in revenue from our Medicaid and Healthy Michigan capitation perspective. The remainder of our funding sources are going to be pretty consistent year over year. A quick note on the county funds. At this point, there's only 1/4 of county funds that are reflected here. We do anticipate that by the end of the year, with the other 3/4 that will get recorded, will be pretty close, pretty consistent in county funding. On the expense side, administration is projecting to be a little bit lower in 2020 than in 2019. Some of this is going to be related to some of the decreases in expenses as we've had people taking some furlough time and then some unfilled positions. And this is true on the internal services side as well. And then our provider services, we're estimating that that is going to stay pretty consistent year over year, but there is a decent amount of an estimate in that expense where we anticipate for services that have been incurred but not billed to CMH related to the months of April and May. The one thing that it does not include at this point in time that we do anticipate related to our provider network stability plan is that we will be doing a retro utilization review towards the end of the fiscal year. And if we do identify significant amounts of reduced revenue in the provider network that they were unable to close that gap with certain federal programs, including the PPP program and or the CARES Act Provider Relief Fund program, that we would potentially use as part of our MDHHS required provider network stability plan, some additional Medicaid funding to help offset some of that lost revenue and or additional COVID related expenses. So that is not reflected in here at this point in time and could be significant. It could be a few $1 million. But when we look at projections, even with that not being included, we are projecting that revenue will be up significantly by the end of the year. Expenses will be down a little bit by the end of the year, and looking at potentially at the current rate about a $30 million surplus that could exist by the end of the year. I'll take a quick pause. Are there any questions up through this point of the presentation? Okay. The next page is just a quick, and again, and this is updated through the month of May 2020, an update on the top 10 mental health providers and the amount that we have paid them through our claims system through May. No major changes in the list that we're seeing, so pretty consistent from that perspective. Just obviously we have one more month of payments that we've made. Same story on the top 10 substance use disorder providers as well. So pretty much the same list we saw last month, just another month's worth of payments. So both seem to be very stable at this point in time. Again, we have a page that gives a quick description of the services that each provider provides primarily. And then we get to our revenue and expense projections by funds, or our revenue and expenses by fund source. So again, this is through the month of May. We're looking at about a 14 million surplus in Medicaid. And that's separate from about a $3.6 million surplus in autism, for a total Medicaid and autism surplus of 17.7 million, and a Healthy Michigan surplus of 2 million. So that's approximately $20 million surplus to date, and that's 2/3 of the year. And so that's how we're getting to about a $30 million projected surplus by the end of the year. If we take that 20 million and give another third of the year, we get up to the 30 million. So as a result, we anticipate, if that trend continues, that we would contribute a full 15.3 million into the risk reserve and into savings, bringing us up to our contractual maximum of about 26 million. And if nothing else changed, we would return to the state about 2.3 million at this point in time. And that could grow as our revenue continues to grow. The one, I guess, piece of information that I will reiterate is that this does not include any additional Medicaid funding that we will push out as part of our provider network stability plan. And so our intent, again, to the extent that our providers can demonstrate their need for that funding, because we do have guidance from the state that does require that we cannot double what they're calling double dipping. You cannot use the PPP loans. You cannot use the CARES Act Provider Relief Fund and additional Medicaid funding from the PIHP for the same expenses. We have to be very careful that that's not taking place. But we do anticipate to utilize some of this additional funding in the last quarter of our fiscal year for provider stability. That's the major highlights from the May finance report. The remainder of the report is the same information, just in more of a numbers format. If there are specific questions or concerns, I'm happy to either try to address those tonight or research those for the board.
Richard, it's Lena. I just want to say thank you on this. The way that you have this laid out in consistently sending things to us like this, help us to really understand what is going on. It gives us a better idea of where the money's at, where it's not at, and help us prepare towards the end of the year of what we may have to do at the last minute. So thank you for putting this together this way and making it simple that we can understand it.
I have just a basic overall question, I guess. Why is the reserve so high? I mean, I realize it's there because expenses are lower than revenue, but why are we not in the same situation? Where are we not, is it that we're not spending as much?
So a high level answer to your question, in 2020, at the beginning of this year, the state did a rate adjustment and they shuffled some money across the state based on what's called the entity specific factor. So Macomb County was determined that under more of a morbidity model and with that entity specific factor that the state was calculating, we should be receiving more revenue than we have in the past. So that started October of 2019, where we started getting an enhanced rate for each of the eligibles. And then on top of that, as you can see, sorry, if we jump back, our eligibles, the number of eligibles we've been receiving payments for is consistently higher than they were a year ago. So more per person and more people has resulted in more revenue. And that's the primary driver of our surplus at this point in time. Not the primary driver is not spending less, although we are seeing some reductions in utilization in our provider network.
Okay, I guess that's kind of what I was really more getting at, the utilization, because we don't want our, if people need services, we don't want them to be reduced for other, I guess, for reasons that we have the money this time. Now we have the money. Before we were looking at services and reducing it as needed. And now we've got the money, it looks like, and that's my concern.
Yeah, and I do know that Christina, from a provider network management standpoint, we've been staying very connected with our providers to try to understand where their pain points are, and to try to support them in maintaining the services that our consumers are needing, within the limitations that are required. And again, to the extent that we can provide an enhanced Medicaid rate out of this funding to help the stability of the providers, our plan is to do that by the end.
Kathy, this is Linda. I just wanted to comment. This is what we've been asking for a number of years. Higher funding rate. A better
Linda,
we can't hear you.
We can't hear you over the crash of the waves. All right, anyone else?
Madam Chair, I have a quick question.
Yes.
Thank you, Richard, for the presentation. I thought I heard you say that we're on track now to have an extra $2 or $2.5 million left over that might be recouped by the state at the end of the year. Did I hear you right?
If nothing changes and our additional revenue trend continues, then yes, right now I'm calculating that there would be about $2.5 million that we would have to send back to the state under our current contract.
I'm sorry for interrupting.
Oh, no, I was just going to add a little context. There is discussion that Dave and I have had and that we want to have with the state due to COVID-19 and the concerns that, the pandemic doesn't care about fiscal years or contract years. And we do anticipate additional costs that are going to be incurred next fiscal year. If there is a way the state would be willing to expand or take off the cap that currently exists in our contract to allow us to carry some additional funding over into next fiscal year if needed.
So you're already looking into it. Thank you.
Thank you, Richard. Richard, if I could have the screen share for a moment too. This wasn't can you see the FIA graph? So what we did is to look at the impact of the pandemic on our service delivery. This is the count of people receiving services, and it goes back to October of 19. So October, November, December, January, and February are pre-COVID periods. February automatically dips because it's a shorter month. And then March is when pandemic hit and you start seeing the other telehealth services come into play. What you see there is how successfully we were able to transition to telehealth. So our concern was a dip in utilization. This is actually showing that in April, we had an increase in overall number of people served. And we're, for May, there still might be some claims lag in that month, so that those numbers might go up. And June will definitely go up as those claims continue to come in. So we are tracking it closely. These are specific codes, more on the clinical nature, but we for sure did not see any decrease in the residential. We saw an increase in the community living supports and a definite decrease in the skill building activities as a result of the pandemic. So we are tracking this close. We do have some better data reporting measures in place. And as Richard said, we've been reaching out numerous times now to our provider network, telling them, ask us for help, make your best case, send your information in. So we are reviewing those requests. We've taken action on a couple so far. And we do have, I owe the department an update on our provider stability plan by the end of this month as well. So thank you, Richard. There's no other. I can go back to the agenda. And I believe Helen was up next. Helen, are you on?
I am, yep.
All right, I'm going to stop my screen share and you can take over.
All right,
Thank you, Helen.
try that. Give me a sec here to find my button. All right. There we go. It should be up now. All right, well, thank you. So I just wanted to take some time to give you an overview of the substance use area. I think it's on a timer, so hold on one second. I can get it to go back. All right. So I do know that at our last meeting, I was able to give, I think, a good overview of many of the substance use services that we're responsible for as you looked at our strategic plan that we sent to the state. So in general, some of the major roles that we perform in the substance use division is to determine the substance use needs for the individuals in Macomb County for all the different funding types that we cover. We ensure a full continuum of care for services and contract for those services and monitor those contracts. So we develop and manage substance use budgets, reports, and complete audits as it relates to those services as well. We ensure that the system is compliant with all the rules and regulations, not only for Medicaid and Healthy Michigan and the My Health link as we have on the mental health side, but as you might have noticed over time in our PIHP contract, there's a whole back section of the contract, quite large, that is very specific to the substance use block grant treatment funds and rules. They have kind of a unique set of requirements that go along with those that are different than the mental health pieces under Medicaid. So we make sure that those are all in place. You've heard quite a bit of talk over the last few years over the many grant opportunities that we've had specific to the opioid epidemic. And of course, with all those grants come very specific rules and reporting requirements as well. So we continue to do all that monitoring and make sure those things are in place. We offer the full range of care that we're required under contract and a little bit beyond, in that we do our prevention services as required, which reaches all aspects of our community, early intervention services, which are getting people who are showing problematic behavior and problems, maybe some early use without maybe needing a full diagnosis yet. We really do a lot of focus there on our youth, going into the schools and working there to help prevent a problem, hopefully, and help individuals make better and healthier choices for themselves. We have our outpatient and intensive outpatient providers, as well as our medicated assisted treatment for opiate use disorders on an outpatient basis. We do our subacute withdrawal and detoxification services for those who need medical help and overseeing that they come off of a substance that they're using in a safe and healthy manner. We have our residential treatment services, which are very intensive therapeutic services throughout a day, as well as staying in the residential facility. We have a very robust peer recovery network where a peer recovery coach who is trained and certified with long-term recovery can follow an individual among all these different levels of care as they're moving through the continuum of services. We're able to offer recovery housing opportunities for individuals so that they have a healthy environment to return to once they leave more intensive services or while they're still partaking in outpatient or intensive outpatient services. So tonight, what I really wanted to do was to give you some information on, I'm sure what you've been hearing us talk about over time is our Opiate Health Home Project. It is part of our continuum of care. That's our newest piece, so I thought it might be something you'd want a little more information on. This is really an initiative that really helps us as a PIHP really expand our integrated care with the physical health services and behavioral health services as one project. And it also is another way to help us tackle our opiate use problem in Macomb County. So I'm sure you've heard, I know I've come and others before me have come and talked about the opioid health home grant that we're under that will end at the end of September this year. But just to give you a little information on that grant, it is an optional state plan benefit through the Social Security Act. It's something that the state is doing currently in Northern Michigan region with about 2 or 3 other counties now, but they will be adding Macomb under the Medicaid piece, as well as 2 other counties come October 1st, once the grant is over. There's an incentive for states to do this project in that it provides an enhanced 90% federal match for the first 10 quarters of the project. So from October and going out 2.5 years, the state will have that increased match going along with the payment. So it helps keep that project moving along. It gives states the opportunity to have more flexibility and be creative with an innovative delivery and payment models, as we'll talk about in a moment as we get into that little piece of this part of the project. And it offers a sustainable reimbursement for the social determinants of health. So there's many goals that go along with the health home project. Overall, we want people with an opioid use disorder to do better, be in recovery longer, and have healthier lives. And we're going to do that through improving the care management of the people that we serve, improving care coordination, especially between physical and behavioral health. We know that's a goal overall within our PIHP in many different levels. But this project really looks at pairing that close connection between the healthcare provider, hospital services, and the behavioral health service providers as well. We're also going to look at improving those transitions between the different levels of care, between the primary and the specialty cares, because we lose a lot of individuals whenever they make a transition from any service level. And so it's been a strong focus for us, and this grant is really allowing us to move this project further. The goal is also to generate some cost efficiencies and increase health status for the members that we serve. Some of the core services in the health home project that must be met include the comprehensive care management. And the care management is being assigned to a nurse care manager within the Opiate Health Home Project. They want a nurse level person to be involved with coordinating those physical health with the behavioral health needs to make sure that the communication is clear and is in the best interest of the person being served. There's also overall care coordination for the individual. A lot of times, we know the populations that we serve, it's hard for them to set appointments, make appointments, know where to find that care and do that follow through. So having that as a target area here will really help the overall health of the people that we're serving. Doing health promotions, encouraging people not only in their substance use disorder goals, but also other health related issues, preventative measures, overall health and well-being, looking at all those different aspects and promoting that and educating better on those needs as well. Having comprehensive transitional care plans so that there are goals to help move people along and move them throughout the continuum. Provide not only support to the person that we serve, but also their family or significant others that are involved in their life, helping them understand substance use disorders, recovery, treatment needs, and kind of wrapping around the whole family unit. And making sure that there's appropriate referrals to community and the other social services that are needed. There's a couple major players within this project under the state, and this is also under the Medicaid language. So the prepaid inpatient health plan being us, in this project we're referred to as a lead entity. So just another word to get used to as we go through another naming process for another project. But our role is to implement and manage the contracts, which you've already heard about. We've come forward with some of our new contracting and bringing providers on board, plus expanding to some of the contracts that we already have with some of our medication-assisted treatment providers. We will do the high-level care coordination. We're also the entity responsible for the enrollment of each individual into the project. We are in charge of paying our providers for the service and all the reporting requirements for the state. This project will include using the state's warehouse management system, the WSA, where we'll enroll individuals in there, but we'll also have access to a lot of the data and information as it relates to other healthcare needs of the individual as well, which we really haven't had at our provider levels in the past. The other partners in the project include our health home partners. And so our opioid treatment providers, those are the ones that you've approved for many years. They provide our medication-assisted treatment and counseling services under a licensed substance abuse program. But as you know, we've also included office-based opiate treatment providers, which in our case has been a federally qualified health center and a physician's group as well. So there's certain requirements to be able to be a health home partner, and so we were able to meet those requirements with those new providers. There's some very specific staffing requirements that go on with the requirements under the health home. As you can see here, it has requirements for us per 100 beneficiaries served, as well as our health home partners. So it just kind of gives a little breakdown of having that behavioral health specialist to work on the substance use and mental health needs, having that nurse care manager, as you can see, having a very important role in that care coordination and oversight on the medical issues as well. Peer recovery coaches will take a big lift in this project in that they will be the ones helping the individual get to those other appointments, coordinate those other appointments, and get to some of those recovery areas of their life that they need help and assistance with. There's also a requirement to have a medical consultant and also a psychiatric consultant available at each of the programs serving clients through this project. As you can see, there's several outcomes that the state is looking for, and the federal government as well as ourselves will be looking for as it relates to what we are hoping to see with opiate health homes. I can tell you now that the state has done a lot of the work to see how is the northern region making progress in these areas, and they're seeing a great return already on the funds that they've invested. And being that we're not as spread out and we have a larger provider network, we're hoping to really be able to show some of those very positive outcomes in our area as well. So, you know, increasing outcomes as far as long-term recovery, the coordinated care, accessing other healthcare areas that they may need to. We want to increase that post-hospital discharge follow-up. That's something I'm hoping that with providers having more access to the information in the Care Connect 360 data, that will help, because many times our outpatient providers, they really don't know when somebody has been to a hospital, especially if it didn't result in an admission. So this should be able to be another way to give them more information and more knowledge so that they can do more of that immediate intervention when those situations occur. The goal is to reduce overall healthcare costs to the Medicaid system, reduce unnecessary hospital admissions and emergency room visits, and increase the health information as well. So I know that was a very quick overview. I don't know if there were specific questions about the project that I could answer for you.
Anyone questions? I guess seeing none. Thank you, Helen.
Thank you.
Thank you. If anybody was keeping track, we are now a PIHP and a CMHSP. We became the coordinating agency way back for those substance use services. We are now an opioid health home, a CCBHC, a My Health Link pilot area, all at the same time. So we are unique in the state of Michigan now. we are only the second region to become the opioid health home. And we are the only PIHP to become a certified community behavioral health center. So we have a lot going on. I told Helen after she presented last time how happy I was that she's with us, because she takes care of all the substance use stuff. So thank you very much, Helen.
Thank you.
Next, we have Lori Valué. Lori, are you? There you are. Do you need to screen share, Lori? Hang on, I unmuted you.
Still on mute.
Yeah. Ellen, you have to unmute yourself.
That works.
There you go. Okay. Okay, we can hear you, Helen. Do you know how to do this?
Lori? You mean Lori?
Lori,
Lori, you're
Yes,
up
I
next.
can hear you. And I can see what's on my screen, but I don't think you can.
Right.
Are you on your screen share?
Go down to the bottom of the screen. There's a green button. It says screen share.
Okay.
Click on that.
This worked this morning when I practiced. So of course it would come to me and I would be the one who is not able to do it.
If you email me your presentation, I can do it for you.
Well, that's a little more involved than it sounds too.
It's on page 262 of the agenda. For those that are following on your agenda, page 262.
I can do that.
Okay, can you see at least something here?
Yeah, there you
There
go.
it goes.
All right, so now let's see if I can get you to slideshow. There we are, yay. Can you all see that?
Yes.
Okay, so many of you already know a little bit about this. Many of the board members have come from the Citizens Advisory Council. But tonight what I'm going to do is just give you a quick little overview of it, a little bit of its history. And then going forward, we will be doing other things, having other members of the CAC and possibly doing other projects. But this is just to kind of get the ball rolling on that a little bit. So what is the CAC? Most of you, or a couple of you, know this already because you came from the CAC, which I think is great. But the CAC is comprised of primary and secondary consumers of our services or of mental health services or substance use services in general. In other words, they don't all have to be folks that have used our services specifically. And the object of it is to provide an avenue for the folks that we serve to get to you, to get to the leadership of the organization and to the executive leadership team so that we get direct feedback on what is important to the folks we serve. The CAC was established by board action in 1994. It was the first Citizens Advisory Council in the state, and it was the model for subsequent state requirements. Basically, the purpose is to give an avenue for that population, for the folks we serve, to provide some feedback on the range and quality of care to customers of our service, to give some firsthand advice and support as to what the experience of using our services is like. Specifically, these are things that came from the original proposal that the board developed in 1994. The board at that time was very specific about what they were looking for. And again, remember, this was a new thing at that time, but to give the opportunity for non-professional family members, advocates, et cetera, to have a voice in the development of services that affected their lives. And to, again, just to have a direct avenue to the leadership team. So that was a novel idea. Some of the things that they're typically involved in is the annual plan. Again, Cindy provided a lot of information earlier at the front end of the conversation tonight. And a lot of that material that she talked about, those quality documents, also pass by the Citizens Advisory Council, so that that group is involved in those issues as well, customer service issues, customer satisfaction, etc. So the CAC members, most of them are also actively involved in other groups. We have members from NAMI, we've historically had members from ARC, various other groups, the Disability Network of Oakland Macomb, autism groups, etc. And part of the group's role, the Citizens Advisory Council's role, is to serve as a sounding board for that group. So in other words, to bring not only their own experience, but the experience of the groups they represent. So, so we have some reach into the community, maybe to folks who aren't using our services and could be. Typical activities, just so you, you know, have a sense of what they do. They're informal communication liaisons, as we said. They're available for audits, CARF reviews, and other outside evaluations. Oftentimes those groups and audits want to hear directly from people served, and the Citizens Advisory Council often helps with that. The Citizens Advisory Council often has a lot to say about the experience of using our service, satisfaction, different things at the request of the Quality Division. We have seen, or the Citizens Advisory Council has seen, historically some of the substance use activities that go on too. We do have a member who represents the substance use community, who's a very good and very vocal member and very helpful in getting the word out. One of the things the group typically does too is they're involved in reviews of requests for proposals. So when the network operations team is looking to add some additional services or additional services providers, oftentimes CAC members are involved in that selection process. The CAC members were very involved at both times when we have reviewed and updated our mission statement. And they were very vocal and interested in that one. That was a good one for them as well. Our Citizens Advisory Council does a lot for us with outreach. Obviously, we're all a little restricted right now because of COVID, but our CAC does an excellent job with a lot of outreach, getting materials out to places for us or with us. They're very good when we have had like the state presentations, when we've had the state representatives, or when we need to speak to elected officials. The CAC members actually in many ways carry more weight because of their experience as service users, and family members often carry more weight with legislators and other elected officials than when we come in as staff members and say, this is what we need. So one of the things too that the CAC has done recently is be involved in the updating the website and in printed materials that come out. So most of the member-facing materials, or many things that do come into the hands of the members we serve, pass through the Citizens Advisory Council first. And my favorite thing about the CAC that is not on here is that it's an excellent training ground for people who become subsequent board members. And it just does a little thing for my heart when a member of the CAC subsequently then becomes a board member. So the CAC consists of 8 to 17 members. This is all based on what the board originally designed for it. Presently, there are 9 active members, and all the members are primary or secondary beneficiaries. And many of them are affiliated with advocacy and community groups. So they're, again, they're not just people who use our, not that that's a bad thing, but they're not only there because they are people there who use our services, but also because they are connected to other groups. So our meetings, according to the plan, are at least quarterly, but this is an active group and they like to meet monthly, except usually we don't meet in July. So they're very engaged, very engaging. Not a single one of them is shy. So you will be meeting different members, I think, in the future. We'll be looking at bringing different folks in. Our chair of the Citizens Advisory Council is Don Nagy, and his name is on this presentation as well. He was involved in this with me, and it was my plan to have him speak, but he texted me tonight and says that he's having technological issues and he can hear and see us, but he cannot speak. So he's with us, but not able to speak to us. And so he just asked me to share with you that we will be continuing to bring to you different issues and things that are of interest to the council. The group is very interested in working closely with the board and working with you to work on things that are of value to the organization as a whole. So I think that's all I have. Oh, what are they doing now? Okay, so the CAC has agreed to serve as the advisory group for the Developing Community Behavioral Health Care Center. They have an ongoing interest in what's going on with provision of services during the pandemic and making sure that people continue to get the things that they continue to need. They will be reviewing the annual accessibility survey. The accessibility survey is a feature of CARF, and it requires us to look at the physical and other barriers within our system that make it difficult for people with disabilities to use our service. So the CAC is often very involved in both in providing input into that and letting us know where we can improve our accessibility, as well as looking at the whole document when it's completed to provide commentary on what we can do systemically. As well as a feature right now is ongoing review of our membership needs and how our CAC membership can best reflect the needs of the organization and the community. So if you would like more information about the CAC, or if you know anyone who you think might be a good member for the Citizens Advisory Council, please feel free to contact me or give the person my name, and we will be happy to work with them to see if we can bring them on. Or if you have any other questions yourself, please feel free to contact me at any time. So, does anyone have any questions about the CAC?
Lori, I think there's at least one other person. Are there any other people from the CAC that are listening in tonight?
Okay, so what I now need to do is switch this presentation. How about let's try new share?
You can close that one.
Okay.
There.
I see Carolyn has joined us.
Is Carolyn a member?
Yes, she is.
Of the CAC? Okay, great. Thank you for joining us, Carolyn.
And then let's get this other one on here. I do not know why I can't get this to show up. There, now can you see local appeals?
No.
All right.
Do the screen share again and click on that screen.
Okay, you're still seeing the Citizens Advisory Council.
No, we're seeing nothing.
Yeah.
Okay, well, I can't get out of that one.
There you go, Laura.
There you go.
I just have to move you guys over. Lori,
Well, okay, I don't know what's happening to me now because now all I can see is the CAC.
There it is.
that's good. So now you're doing local appeals, Lori.
Well, but I can't.
I know, I have it. Just tell me when you want me to advance the slides and you'll be all set.
Okay, but I can't see what you're seeing.
Can everybody see where it says local appeals?
Yes.
Yes, that's on this.
Yeah, but I can't. Oh, I see. Okay, well, I've got a paper copy.
There you go. You can just close the window too, maybe. But
Okay, so my full-time real job is to be the local appeals officer, or it's now called the local appeals coordinator. So I am responding to folks who are not satisfied with decisions that have been made about services that they have requested. So a beneficiary can appeal a decision to reduce, deny, terminate, or suspend a requested service or its amount, scope, and duration. So what's been granted or how much or how long. Person could also appeal the content of a plan of service or eligibility for family support subsidy payments or fees for services if they are non-Medicaid beneficiaries. Can also appeal certain other administrative actions of the PHP, which is basically if we miss a deadline or do certain things out of sequence. So the next slide, who can request a local appeal? Federal rules allow the beneficiary, the parent of a beneficiary under the age of 18, or the appointed guardian of the beneficiary to request a local appeal. Or the authorized person, that is the one who would normally have the ability to request an appeal, can also designate someone to serve on their behalf, which is an authorized hearing representative. That would have to be done in writing, and it can only be done under certain circumstances, but mostly it's fairly straightforward. What happens at a local appeal, that's the next slide. What happens at a local appeal? Rules allow for a local appeal to be in person or a record review only, typically at the beneficiary's request. Now, right now, because of the pandemic, obviously we're not meeting anyone in person. And we are permitted right now during the period of the pandemic to use telephone or video conferencing as an in-person alternative. The local appeal is the beneficiary's opportunity to provide additional information that they may or that may not have been present at the time the first decision was made. So additional information, that means like additional evaluation materials, additional documentation from schools, evaluations, and any additional documentation or insight that they have about why it is that they feel they need the service that has been requested or denied. So what happens then? Okay, so I meet with or talk to the person on the phone or in person when we could, and get from them what it is they want us to know, any additional information, and then all of that information that's provided in the appeal is reviewed along with all the records and all the information that that we have in the record that allows us to arrive at whatever decision we've arrived at. Now, when, as I often say when I'm working with people, when it comes to me or when it comes to the appeal process, it's a brand new set of eyes, not affiliated with the Access Center or with the clinical team that may have made recommendation. But decisions are reviewed against the Medicaid and contractual requirements that we have, including medical necessity and any requirements for the service that they've requested. So the next slide, appeal determinations must be made within specific timeframes and by persons who were not involved in the original decisions. And typically when I'm reviewing a case, I will often engage other people who may have specialty knowledge. For example, an autism case, I will often engage our autism benefit manager, or a children's services case. I will often look to the children's team to provide additional information, substance use disorder, etc. So, so that the person has the fairest possible chance to get what they need. And according to the rules, decisions involving hospitalization and certain hospital alternatives must include consultation with the medical director. So anytime someone is trying to get into the hospital, the doctor would also be looking at it. There are some additional appeal options or additional means of being heard. A second opinion is requested when initial admittance, or can be requested when initial admittance to service is the issue. In other words, the first time getting through the door. And also may be another way of requesting hospitalization. Second opinions are typically done before a local appeal, but may be done at other times as well. Following a local appeal, there is also a second opportunity for someone who may not be satisfied with the results of a local appeal. They have the opportunity to use a Medicaid fair hearing, or if they're not a Medicaid beneficiary, which we don't have very many of those right now, but if they're not a Medicaid beneficiary, there is also a second level alternate dispute resolution process for them. And as I often say to people, our door never closes, because even if they are denied a service at a given time and that action is upheld, if the beneficiary's condition changes, they can always re-request a service and re-present. So each decision is its own decision, and the person can always ask again for something that they feel that they need. So the next slide, just to give you a little bit of information about what the volume is typically. In 2018, there were 468 local appeals. In 2019, I do go by the calendar year. I took the function over in January, and I started my record keeping when I took the function. So therefore, I keep all my data by calendar year. So in calendar year 2018, for example, there were 468 local appeals. In 2019, there were 286. In the first half of 2020, there have been 75. A typical year has about 250 to 300. We'll come back to why that number is so low. People often ask, what are my most contested services? The most contested services typically are CLS and respite and specialized adult residential services. The vast majority of my appeals are for those services. I would say roughly 2/3 of my appeals are for those services. Approximately 75% of the actions of the PHP are upheld at the local level, and about 25% are overturned, modified, or withdrawn by the beneficiary. And these outcomes are very similar to what other PIHPs manage around the state. Now, the pandemic has had a pretty significant impact. This is the next slide. The pandemic has had a pretty significant impact on us in a sense, or on appeals, because there were some requirements put in place at the time of the initial stay-at-home order that essentially said, you know, to hold people harmless in terms of service. And so during the time of the stay-at-home order, we were very much prescribed as far as what we were able to reduce, deny, terminate, or suspend during the stay-at-home order period, which meant there were less services denied and therefore less appeals. And that's why you see the number of 75 for the first few months versus what it would typically be. Now that the stay-at-home order is somewhat lifted and there have been other lifting of some restrictions, we're starting, there are a few more denials, and so therefore there are a few more appeals. It's really difficult to tell right now what is going to, how the pandemic will continue to impact appeals. So really, this is very, very brief. Every appeal is considered individually, and every situation is different. And I do try very much to give people the best opportunity to be heard. So does anyone have any questions about that or about the appeals process?
Lori, I have a question. This is Kathy. Do you keep any kind of a satisfaction record, or will that be something that will be part of what you do in the future?
Satisfaction with what?
With the people we serve, their satisfaction level with the process. They may not like the outcome, but do you have an idea if they feel satisfied with, they got a fair hearing anyway, or now better understanding of why they were denied, things like that?
As far as a formal way to keep that, I haven't, done that. I do know that obviously if they're not satisfied with the outcome, they have the option of, going on to a Medicaid or to a next level appeal. I do rather miss being able to meet with people in person, because I am able usually to spend considerable time with people if necessary to help them understand what's going on and why it's going on. Sure. So I do kind of regard it as part of customer service to be able to do that and to at least present them with a decent understanding of what's happening. Sure. So, but as far as a formal keeping track of that, I don't know. I suppose there would be the possibility that someone would have, if they had a grievance, that would be an indicator.
Sure. All right. Any other questions?
I don't have a question. I just have a comment, though. I want to give kudos to Lori. We had a particularly difficult case going on, went through the appeals process, went through 2 executive directors trying to resolve them, and they finally worked their way to Lori, and the next day I get a call and say, okay, it's all taken care of now. So I don't know what you did, because I don't think there was any major changes in their level of service, and the personality, the dispute wasn't cleared up in and of itself. But whatever you did it right.
Well, thank you. I very much appreciate that. I really do, Nick. I think that since I've had this role, I really truly have tried to at least humanize the experience for people. I may not be able to give them what they want, but I can be decent to them. And that goes a long way.
Yep, sure does. Thank you, Lori.
Thank you.
Anyone else? Well, thank you for your reports. Dave, did you want to add anything?
I was just giving Sandy a hard time for leaving me off of the list of management reports.
Okay, so anyone?
The leadership team has done such a wonderful job that, I could keep my remarks super brief. Just to remember the
current out of order.
Through the chair, may I give a CEO update management report?
Yes, you may give a short management report.
Very short, yes, thank you. The CARF survey is required. It went out to the board members. We have 7 responses, so we're missing 5. We do have the Mental Health Authority Task Force meeting scheduled for next Tuesday, the 28th at 9 o'clock. I'll leave it at that for tonight. I'll send you guys an email with some other updates and stuff. But yeah, the team covered quite a bit of information. We will work on the schedule to try to keep it, you know, break everybody up over time. But I do want to thank everybody who did present, and I'll keep my comments to that.
Thank you. It is very helpful when we do hear from leaders in the organization when they report on what they do, because we hear a lot, it's on our agendas a lot, and sometimes don't have an understanding of exactly what they do. So this helps a lot. Thank you. Again, I'll also remind you, those who have not done the survey, the board survey, please do so. If you don't know what Dave or I were talking about just now, please contact Sandy and ask her to send that link back out to you. And that brings us to item number 13, hearing of the public. Is there anyone from the public that would like to address this board?
Hi, I would. My name is Carolyn Gamicia.
Thank you, Carolyn. Go ahead.
And I just wanted to thank Lori for the presentation on the CAC. I am an active member currently on the CAC, and I do think that it's very important that for this county that we have such a avenue to bring voices to the table of not only secondary consumers, but advocacy groups that represent them. The reason that I wanted to make public comment today was my concerns regarding the premium pay that is supposed to be received by direct support professionals or care providers that work in Macomb County. I have looked at that premium pay that is supposed to be a $2 pay during the COVID pandemic period for direct support professionals to provide either respite or CLS hours to individuals within Macomb County receiving services. Currently, I did watch the last meeting, and I did hear Dave indicate that money was requested from the executive's office regarding starting to pay some of those the individuals during this time. As many of you know, if you have loved ones that have some direct support professional supports, they are a very underpaid and underappreciated group of individuals and employees. So my concern during this time was that some of those individuals were not receiving the premium pay or COVID, pandemic pay, which was put forth by the state to begin in April, to add that $2 hourly wage to individuals providing services from April through July. I don't know if that's going to be extended, but I have spoken to several families, including our family, and that pay has not been realized since April. I have asked why, and I have received information from the fiscal intermediaries that the pay has not come forth because Macomb County has not received that pay to be able to do so. However, when I watched the June, I think it was the 24th or 25th meeting, Mr. Panikai had indicated that some people were receiving that pay. And it's my understanding when I spoke with people and I looked into this, because people were having a very hard time, keeping staff during this period. We have a very hard time outside of a pandemic. So you can imagine trying to hire someone who's getting a little bit above minimum wage to work during these circumstances. So I'm voicing my concern today because I was able to obtain information that I do think, and Dave, you can correct me if I'm wrong, but the contracted agency that provides respite and CLS through Macomb County CMH for homes like adult foster care or the adult respite home, we're getting that premium pay as opposed to the individuals under self-determination contract who are not receiving that premium pay. I'm just making this comment because I do think that it's important for us as a county to realize too, when that's not transpiring, it's just going to make it that much harder for people that may be having a hard time during this crisis to make it through to the next day. I have reached out to other counties and I have spoken to other individual families and advocacy agencies, and many of them were providing that premium pay with the knowledge that the state would then in turn provide those funds to reimburse their general funds or COFR funds.
Okay, Carolyn?
Yes.
Thank you for bringing that to our attention. We have a 5-minute rule.
Okay.
And you're near that, but we will make sure that there's some follow-up regarding that issue, and somebody from the department will get back with you. Okay.
Thank you so much. I appreciate it. Thanks for the opportunity to provide the info.
Is there anyone else that would like to address this board? Anyone else from the public?
Yeah, I can continue on if I could. Andrew Gamicia.
Okay, you have 5 minutes.
I just want to make sure that the information is correct, that the extra pay is going to the group homes and adult foster care, and not to self-determination. If Dave could address that, that's all I've got.
Okay, and that answer will be provided for you, and we can get a report back to the board members. We would like that information as well. However, we just don't engage in back and forth at the meetings. But that's a fair question to ask, so we will get that information to you.
All right, thank you very much.
All right. Is there anyone else from the public that would like to address this board? Anyone else? And this is the last call. Hearing no other requests to speak, this meeting is adjourned. Thank you, everyone.
Thank you.
Thank you.